today I'm just going to, we already saw some content from these models. I'm going to present the AHHME model family, which we're using at the London School of Hygiene, which does basically what we're talking about in this workshop, evaluating the holistic impact of AMR and AMR interventions from a One Health perspective. So yeah, I'll just basically go over the model, why we felt the need to create it, and then talk about how it's structured in a fairly overview way, just because I don't want to get bogged down in too much detail, but I can answer specific questions afterwards. And then show some example outputs from the models to give a more tangible idea of what we do with it, talk about applications so far, how it could be applied to Singapore, and then the resources that we've created associated with the model, so our online codes, Shiny apps, stuff like that. First, just briefly talk about the consortium. So I'm part of the SAFASI consortium based at the London School of Hygiene and Tropical Medicine, which looks, the ultimate aim of the model is to use One Health, health economic analysis to select antimicrobial stewardship interventions in agriculture from a One Health perspective. And we look at England, Senegal, and Denmark, although we collaborate with collaborators from other countries as well. And we also want the outputs to be internationally transferable. And so here you can see our consortium logo. So yeah, AHHME is the agriculture human health microeconomic model. It functions at the national level, and it considers a few different outcomes from AMR. We look at obviously the life years lost to illness, so that's using a QALYs framework. But we also look at the effect on labor productivity, and that's both paid labor, but also unpaid labor, so caring work, volunteerism, household labor, that sort of thing. The cost to the healthcare system, and because the model has so far been applied to agricultural contexts, we look at the effect on agricultural productivity. Although the model is modular, so it does not have to look at livestock production, which is what we've used it for so far. It can be used for other things, but we'll get into that later. There's also the AHHME, which uses the same basic framework, but it estimates the burden of AMR using these same basic outcomes. But instead of intervention analysis, we just look at the holistic burden at the national level, and that's both the attributable and the associated burden. Yeah, the reason we wanted to create these models is because AMR is often, although not always, considered as a human health issue. What is the effect on healthcare costs and human life years lost? Although it's a One Health issue, it's a societal issue, and not considering these more holistic health economic, socioeconomic impacts may mean that we underestimate the burden of AMR. And also when we look at interventions, we might under-prioritize those interventions using a healthcare-centered approach to cost effectiveness analysis. Another thing we wanted to achieve with these models is to have a lot of parameters that can be customized to the country context, to the intervention or interventions which are being looked at, or to whatever sector is most important in the country that it's being used in. So yeah, there's a human and an animal epi model. Both use Markov state transition models based on a series of difference equations. Essentially, we have a human population. It exists, it can grow, and people transition between health states. In our model, we do not have the exposed category that we saw earlier. Instead, we have well, susceptible and resistant infections, dead, and also a category for sequelae. And we have transition probabilities between all of those states. We run the model over a series of annual periods, and then sum the number of people in each state in each period and apply health economic values to the people in each of those states from the 4 perspectives, which are, again, human life years, labor productivity, healthcare costs, and agricultural productivity. And then we also discount. The animal epi module is quite similar. They also transition between health states. There are livestock populations, and there can be multiple populations. So we can have, for example, smallholder and industrial farms. We can have different livestock species. And it's modular again, so there can be multiple different types. Like you might want to have commercial, backyard, and semi-intensive farms, for example, or you might want to look at additional livestock species, and these can all be parameterized separately. And rather than assigning a value to the animals based on quality of life, we just look at the number of animals which survive long enough to be sold at the end of the production cycle. So we look at that just from the perspective of agricultural productivity. And even though the model uses annual periods, there can be multiple production cycles per year. So for example, with chickens. And then again, we sum the number of animals that are sold in each period, and we discount future periods using our discount rate. So yeah, basically for the human epi module, we run the epidemiological module, and at the end, we have a table with the number of people in each health state in each period. And then we assign health economic values to them, the quality adjusted life years lived in each state. So for example, we might say that somebody who has a resistant infection and then recovers, they will experience a subjective loss in quality of life. Somebody who has a resistant infection but then develops sequelae afterwards, they will also experience a loss in quality of life. Obviously, people can die, people can have susceptible infections. We also look at the cost to the healthcare sector associated with each of those states and the effect on labor productivity. And for illness, we just look at the amount of time that people are in hospital and not working. But then for death, we can use the friction cost and human capital approach to estimating productivity losses. And that's something, yeah, a bit more detailed to discuss later, perhaps. Anyway, we sum all of these values, we discount future periods, and this gives us an estimate of sort of the total health economic welfare experienced by the population during the period being considered. And for animals, similarly, we just look at the number that end up being sold. We can also look at the effect of infections on the finishing weight. So this can affect the sale price. And then we sum all of the sales and we can discount future period. And then instead of assigning health economic values from these three perspectives, we just look at the sale price. And this is added to the measure of health economic welfare alongside the outcomes used for human health. And then in order to produce our outputs, we run this model. We have the animals and humans moving through health states. We assign values to those health states. We sum these. We have an estimate of health economic welfare. And now to get an output, we compare this to a counterfactual. So for AHHME, which is intervention cost effectiveness analysis, this counterfactual is we now have an intervention. The intervention changes one or more of the model parameters, and there's about 100 model parameters. So in theory, the intervention can affect all of these or just one. We've been looking mainly at antibiotic stewardship in livestock production. So naturally, the parameters that we would change with the intervention could be finishing weight, animal mortality, and then also if antibiotic stewardship in livestock production influences zoonotic transmission of AMR, we can look at the rate of resistance in human infections, also the total number of human infections. But it doesn't have to look at livestock production. I think Dr. Go will talk a bit about wastewater. We could also have an intervention which affects environmental transmission of AMR. So this could affect, for example, wastewater treatment could affect the instance of AMR in human infections, the total number of human infections. It could incur an intervention cost. And it could affect all sorts of things. Or it could be a simple like hospital hand hygiene intervention. This could incur implementation costs and then influence nosocomial transmission of AMR or affect the mortality from infections. Basically, if it has a parameter in the model, it can be altered by the intervention. It could be a very rogue intervention which just speeds up the production of livestock animals, for example, or it can be a purely human health focused one. In any case, we rerun the model in this intervention scenario where the parameters have changed. And then we just compare the total health economic welfare with what we had in the base case scenario. And this gives us an idea of the total benefit of the intervention. Then this can be converted into like a threshold price, so a price of implementation beyond which the intervention becomes unacceptable, or if the implementation cost is known, this can give us the net monetary benefit of the intervention, that sort of thing. And yeah, so this is from when we looked at biosecurity interventions in livestock production. This is just a brief overview of the causal pathway. We have the intervention, which is the white box. And in that situation, it affected 3 of the model parameters: the rate of AMR in human infections, the rate of AMR in livestock animals, and the finishing weight of the livestock animals. It could also affect the mortality. It could also affect a number of other things. And then in purple, these are the health economic values that are affected by those changes as a result of the intervention. And then we sum those to get the cross-sectoral net monetary impact of that intervention. For AHHME, which estimates the burden of AMR, the counterfactual is a bit different. We do the same thing. We run the model in the base case, and then we run it in 2 different counterfactuals. If we're looking at the attributable burden of AMR, the counterfactual is when all of the resistant infections are treated as if they had been susceptible infections. So we get an idea of specifically the additional burden incurred by the resistance of those infections. But then for the associated burden, we rerun the model as if all of the resistant infections never occurred. And we compare the base case with the counterfactual, and then instead of an intervention benefit, it is the burden which we get as an output. So conscious that this workshop is talking about modeling with respect to Singapore, looking at biosecurity interventions in livestock production is unlikely to be a priority because most food is imported. Obviously, in the countries that we're looking at, it is more of a priority, so that's what we focus on. When looking at the burden, obviously the livestock production module can still be included, but the model could equally be run without it. For intervention analysis, there's a lot of different things that could be looked at. We could look at food imports as a potential source of AMR transmission. So could look at something to do with safety standards, processing. We could also look at interventions like hospital hand hygiene interventions, built environment interventions, which was mentioned earlier, water treatment interventions, all sorts of things like that. As long as they alter a parameter which feeds into the model, we can look at an intervention which targets that. So the potential to apply it in Singapore is absolutely there. It just needs to define the intervention in terms of the model parameters. So yeah, just a more tangible example of what kind of outputs the model produces. This is very much demonstrative. For this one, we created hypothetical settings where all of the population level parameters were the weighted average of countries in each of the World Bank lending group, lending groups, so high income, middle income, and low income, and looked at a hypothetical country which is representative of that income group, which had a population of 100 million. And then looked at a hypothetical livestock biosecurity intervention, which had a given effect on the rate of AMR in human infections and a given effect on livestock productivity. And then the outputs that you see here are the net monetary benefit of that hypothetical intervention over a 20-year period. So these are not concrete real-world data. It's just to illustrate what kind of outputs the model produces. But yeah, using the hypothetical parameters that we used, obviously the intervention looked to be very, very cost-effective, except in a very limited scenario. For AHHME, unfortunately, the size of the text is not very, very good, but I'm just going to come around to read it, sorry. Yeah, okay, so the top and the bottom charts show the model being run with either the friction cost or the human capital approach to estimating productivity losses from mortality. And we can see the associated and attributable burden of AMR again, this is with in a hypothetical context. On the left, you see the associated and attributable burden, and then the other columns show that burden disaggregated by sector. So what portion of that burden comes from the loss to human life years, what portion of that burden comes from the loss to labor productivity, healthcare costs, agriculture, that sort of thing. So this is the kind of output that you will get when looking at the burden of AMR with the AHHME model. Of course, we can also run sensitivity analyses. So in this situation, this is from AHME as well. We attached a distribution to some of the main parameters of the model, and then did Monte Carlo simulation to run the model. I think this was 10,000 times. And then this shows the distribution of the burden after varying all of the major parameters 10,000 times. And as you can see, like there are some very extreme outliers simply because of the amount of uncertainty in some of the major modeling parameters. And this also highlighted for us the importance of methodological parameters. So a lot of these parameters like willingness to pay threshold or the discount rate or whether what approach was used to estimating productivity losses in the health economic literature are usually just selected using rules of thumb. Like, okay, in middle income countries, just use a discount rate of 4% or something. But we found that varying these parameters even a little bit had a very, very large impact on the estimated burden of AMR. So it kind of highlights the importance of exploring those parameters and also having a good justification for what's chosen beyond rules of thumb. We can also do tornado plots. So this shows this is also from AHME, but the same kind of sensitivity analysis can be run for the AHME model. It shows the variation in the burden, which can be attributed to variation in each individual parameter along the distribution that we assign to it. So, for example, so for example, if the discount rate that you're using in the context, maybe you're aware that it varies between like 4 and 5%. This plot will show you the effect of varying that within the range that you've assigned to it. So again, you can see that the methodological parameters sometimes have a greater impact on the outputs than the epidemiological parameters. This doesn't mean that they're more important in real life. It just means that maybe there's more uncertainty attached to them, or the way that they feed into the model influences the effect of those other parameters. Yeah, so basically, so far with the model, we're collaborating with Chantal Morel, who will do a presentation, I think next or later today, to apply AHME to estimate the burden of AMR in Zambia and Malawi. For now, we'll start with estimating the burden of 1 or 2 specific pathogens and then go on to apply that and maybe get a broader estimate of the total burden of AMR. We've also produced the results that I showed you earlier, these ones, and that's just looking at how livestock biosecurity interventions have different effects varying by country income level. We have published a paper about the AHME model in One Health, and I think this is actually in the presentation earlier. That's recently been accepted for publication, so that's good. And then we presented these models at a few conferences and now at this workshop as well. And then, finally, there's the AHME paper, but then we also have a GitHub associated with the AHME and AHME models, and we also have an online interactive Shiny app associated with each of these. So for both of these Shiny apps, it's web-based. You can just run it in your browser, and you're able to edit the model parameters. So you can download, for the AHME model, you can just download the parameter sheets and manually edit it to reflect the context that you're interested in looking at. And then just upload that and you'll see that the burden associated and attributable burden of your chosen pathogen in the country context that you've parameterized it for, and also the portion of that burden which is attributable to each of the different sectors that the model looks at. So these resources are more for, the Shiny apps are more for exploratory analysis, maybe to help define research questions or to get a broader idea of the effect of different parameters on model outputs, or to identify priorities within the research context that you're interested in. Whereas By accessing the GitHubs, you have access to all of the model code. It's open source, and there's also instructions on how to apply these, and also to edit them using the modular nature of the model and do analysis in your context of interest.